Hi, everyone. I'm Jeff Seaman, and I'm honored to serve on the board of the Scleroderma Research Foundation. I became passionate about advancing scleroderma research 5 years ago when my daughter was diagnosed with systemic scleroderma. Seeing all of you here today is a powerful reminder of the collaborative strength of our community that fills me with hope for the future. Before we dive into our session, just a few quick notes to help you get the most out of the day. Each presentation runs back to back and starts automatically, so no need to leave or log in between sessions. Secondly, please submit your questions anytime during each session using the Q&A panel, which is on the left side of your screen, and we'll answer as many as we can before the end of the session. All right, let's get started. It's my pleasure to introduce our first session, Understanding Scleroderma, the Essentials, led by Dr. Marcin Trojanowski. Dr. Trojanowski is a board-certified rheumatologist at Boston Medical Center and clinical associate professor of medicine at Boston University Chobin and Avesian School of Medicine, BMC. He completed his medical degree at the Medical University of South Carolina, followed by residency at Georgetown University Hospital and fellowship in rheumatology and MUSC with an emphasis on scleroderma. Dr. Trojanowski serves as the clinical director of the Division of Rheumatology and director of the scleroderma program at BMC. His work focuses on systemic sclerosis, interstitial lung disease, and innovative models of autoimmune care. He is the principal investigator on multiple clinical trials and co-investigator on NIH-funded research in scleroderma fibrosis. He is an active educator and mentor, has received multiple teaching awards, and regularly presents on systemic sclerosis and rheumatology topics at regional and national forums. Please join me in welcoming Dr. Trojanowski.
Hello, I'm Marcin Trojanowski, Dr. Trojanowski from BU Chobin and Avedian School of Medicine and the BU Scleroderma program. And it's my delight to be able to talk to you about the essentials in understanding scleroderma. Just a little curious point there in the top right corner of my slide. I do have a beautiful painting by Swiss-German artist Paul Klee, the Insula de la Camera. He suffered from scleroderma, and his style of his painting changed throughout his life, and many people suspect that it was due to the scleroderma that he went from more of a realist to more of an abstract painter. So I always take inspiration from that. Let's start with the terminology. As a scleroderma patient, you probably go into the doctor's office and you're flooded with different terms, and they seem to meld together, and it can be really hard to keep things in order in your mind. So I wanted to discuss some of the basic terms that we use. Scleroderma is the general umbrella term that we use for the whole disease process, but it's definitely broken down into different subgroups. Systemic sclerosis, which is typically managed by rheumatologists in the US, is a systemic disease that affects both your skin and your internal organs. Localized scleroderma is more commonly managed by our colleagues in dermatology, though sometimes certain specialized scleroderma centers will see localized scleroderma. And in those diseases, they have less internal organ involvement, very rare, save for a few exceptions. Let's go over to some of what these look like in pictures. In systemic sclerosis, you can see in this patient the whole body is affected. Even the color pigmentation is lost due to the changes in the skin. The blood vessels are also almost in every scleroderma patient are affected in the form of Raynaud's phenomenon, which many patients with scleroderma will suffer from. And in this patient, you can see the color changes happening at the tips of the fingers. Eventually, the fingers and hands can take a kind of clawed appearance as those tendons tend to retract, and the skin gets very tightly wound against the fingers. You can also see loss of fingertips. And lastly, but not least, the lungs can be affected, both in the blood vessels in the lungs and in the form of the lung tissue itself getting scarred. Now let's contrast that to localized scleroderma. These are more often localized to a specific area in the form of linear scleroderma, which can go down the line. Very devastating disease that will affect the tissues underneath the affected skin. Or it can be rounded in the form of morphea. Also can be indented and also can have some loss of pigment as well, but a very different disease than systemic sclerosis. Now, for the majority of this talk, I will talk specifically about systemic sclerosis. It is further subdivided into two primary elements. There's diffuse cutaneous systemic sclerosis and limited cutaneous systemic sclerosis. Now, some of you may have heard the term CREST before, and in some patients, I may have used that term myself. That is an older name that we use for limited cutaneous systemic sclerosis. It's an acronym: calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Now, the scleroderma community has moved away from that term primarily because it doesn't fully reflect the breadth of the disease, and we felt that limited cutaneous systemic sclerosis was better. Now, on the bottom of the slide, as you can see, I have two other little bullet points. One is systemic sclerosis sine scleroderma. That is a disease where a patient does not have the skin findings at all. Though they still can follow the general pattern of the other primary columns, they can fall into either one. The other is an overlap disease. Some patients have more than one disease. They can have scleroderma plus another connective tissue disease like Sjogren's disease, lupus, myositis, or rheumatoid arthritis. So these are kind of away from the other systemic sclerosis subgroups. How do we tell the difference? And is there one that's worse? How do we tell the difference between scleroderma? Well, the definition is primarily made based on how much skin is covered by the thickening that happens. If it's just your face, your hands, and the area below your knees, then you are by definition limited scleroderma. If it is your whole body potentially affected or anywhere interior to those areas, then you are by definition diffuse. Both these diseases have much of the same story, but there are subtle differences in what a patient can experience. For example, the interstitial lung changes that you saw in that picture earlier in this talk occurs in about a quarter of patients with limited scleroderma, whereas the diffuse patients, it's about half. The pulmonary hypertension, which is an effect of the plumbing of the lungs, occurs in about 20% in both. Renal crisis, which is scleroderma affecting the kidneys, is extremely rare in both disease subsets, but it essentially never happens in limited cutaneous systemic sclerosis. And finally, gastrointestinal involvement like reflux and many other manifestations occurs about equally in both. Now, you've gone to the doctor. They've done blood tests. Let's talk a little bit about some of the blood tests that are ordered for scleroderma and what they mean. The first test I'd like to discuss is the ANA, or anti-nuclear antibody. The ANA test is done in a very peculiar way because it's been around for about 60 to 70 years. They take your blood and take the liquid part out of your blood called the serum. And then they pour that serum over a group of cells, very special, called HEP2 cells. And these cells will sometimes stick to certain components of your immune system. And when they stick, you can add a second chemical to make that stickiness glow. Now, as you can imagine, that's not a very specific thing to do. It's not a very specific test to do. You're just looking for glowing dots on a plate. And this test is not very specific. What does that mean? There, almost 90% and for probably more patients have a positive ANA test. Just having an ANA test does not mean you have scleroderma. That's the meaning of it being nonspecific. Why? Well, ANAs are found in at least 10 to 15% of healthy individuals all around the world. And there's a lot more healthy individuals around the world than there is patients with scleroderma. So simply having an ANA certainly does not bring anyone any closer to having scleroderma or make that diagnosis any easier. It's just the first step. Let's say your doctor then ordered a second set of very specific scleroderma tests after that ANA was positive. I would like to reflect on these in the two primary scenarios that this test may be drawn. One, a patient has a very vague set of symptoms. The doctor does not know what's going on, and they order a battery of tests of all kinds of things. And in that battery of tests, you get a scleroderma antibody, whether that be anti-centromere or SCL70. That's a very different scenario from if your doctor sees that you are starting to develop many of the things that we know about in scleroderma, such as the Raynaud's phenomenon or the thickening of your skin. In the first group, I don't know how much that can change the question of if you have scleroderma or not, because if you don't have the symptoms of the disease, it's impossible to make the diagnosis. And very often we see patients who have no symptoms at all and have been tested for these diseases and found to be positive. And those, all we can do is wait and see. In a patient that is starting to get the symptoms, so we have some confidence that a patient has scleroderma, these tests can be very helpful. One, they can predict some of the manifestations that we would expect. For example, as anti-centromere patients will almost exclusively be limited in their skin distribution. There are others like SCL70, which will more likely develop lung disease. So these can be very helpful for your doctor to predict and to plan for what things to expect as part of your disease. But once again, having a positive antibody alone without any other aspects of the disease does not mean that you have the disease. It's very important to understand. Living with disease. Many patients with scleroderma ask themselves, why are these things happening? We know for a fact that it is some combination of a genetic predisposition and then something turning that genetic predisposition on. We know that from studies that have been done on twins. And then that gets you into this cyclone of scleroderma. It appears to be some combination of microvascular damage, generalized fibrosis, and changes in inflammation derived from your innate and adaptive autoimmunity. The fibrosis, which is the first part I'd like to highlight, is happening in an area called the extracellular matrix. So our body is made up of organs. Those organs are made up of tissues, and those tissues are made up of cells. Those cells are surrounded by a lattice work of different structures and proteins called the extracellular matrix. Now, that should be somewhat of a free-flowing area, almost like an open river. But it's filled with these proteins called collagen. The collagen is extremely important as a protein in your body. It is what gives us our structure. It is when combining with calcium is what gives firm and structure to our bones. It is the primary building block of our muscles and our tendons. So we cannot exist without collagen. But imagine if due to that autoimmunity, that inflammation, all of a sudden the cells, called the fibroblasts, start depositing more and more collagen into that area underneath the skin. And think of that area on top here as the epithelium, as the skin. And all of a sudden, that free and floating lattice work is now getting filled to the brim and bursting with collagen. That is what leads to that thickened skin that you notice as part of your disease. Not to be shortchanged is the vascular damage that can happen too. It primarily affects the smallest blood vessels. We know that we have arteries that go from the heart to the smallest tips of our body, and those blood vessels will start out very big and get much smaller as they get closer to their endpoint. These arteries are very muscular and they can open and close. Now, in the smallest arteries, what we call the microvasculature, in a patient with scleroderma, that same collagen that was depositing underneath the skin can also deposit into the innermost wall of the artery. That area is known as the intima. Now, for anyone who's tried to drink coffee out of a coffee straw and then drink juice out of a drinking straw, you can tell that a much smaller artery is much harder to get liquid through. And as that collagen deposits in the intima of this artery, the inner lining gets smaller that the blood can go through. And the heart and the body has much more difficult time pushing blood to the outermost tips of our body. That is why patients with scleroderma get Raynaud's phenomenon, because when their blood vessels close a little when exposed to cold, they now no longer are delivering blood adequately to the tips of their fingers. Now, treatments primarily revolve around changing innate and the autoimmunity and inflammation existing in scleroderma. This is probably a convention just from rheumatologists who are very knowledgeable about inflammation and knowledgeable in using these medications. I've put several up here: mycophenolate mofetil, rituximab, cyclophosphamide, and methotrexate. All have various degrees of effectiveness in scleroderma, particularly when dosed early. And it seems that lowering that inflammation and that dysregulated autoimmunity does help some of the other components of the disease. We do have medications that we try to deploy to help with the vascular damage. These are primarily medications that will relax those muscles in those arteries and try to promote them to open as much as they can. Now, you have to understand, though, they're not actually changing that thickening intima. They're just opening. So unlike some other components of disease, there's no fix there for the microvascular changes, just a treatment. And finally, when it does occur in the lungs, we do have some drugs that seem to help with dysregulated fibrosis. And an example there is nintedanib. So I often get the question, what about my family? Should I get my kids tested? Should my parents get tested, or my brother and sister? And what are the risks of my family getting, specifically, my kids, etc.? Well, the answer in short is no. As you recall, there's two factors as part of the disease. And even if a person who has a family member has a positive blood test, we wouldn't really know what to do with that in the absence of any symptoms. So we don't recommend generally for family members to get blindly tested for scleroderma, because that just leads to unnecessary costs for the patient. And what are the risks of the family developing scleroderma? It's very small. There have been some studies done on families, and it does show a slight increased risk of the disease versus a general population. But you have to understand that, as I tell my patients, this is like having a lottery ticket. So you have 2 lottery tickets instead of 1. So you're now twice as likely to win the lottery, but it's still extremely small. So we would say that the risks are not great in direct family members. That's all I have for you guys today. Thank you very much. And I'm looking forward to the question and answer session.
Good morning, everyone. And thank you so much for being here with the Patient Forum. And thank you, Dr. Trojanowski. That was a really excellent overview of what to know about scleroderma. Again, thank you for joining us. I'm Sharon Doby, and I'm honored to serve on the board of directors at the Scleroderma Research Foundation. I'm a retired physician and faculty at the University of Washington, and my connection to scleroderma is that my son had scleroderma and died a few years ago from complications of the disease. So you've already submitted some fantastic questions, so let's just dive in. Dr. Trojanowski, I had a question. I see a question that someone had about when you were talking about the extracellular matrix. And I was wondering if ever you can sample that about the amount of collagen. Like you talked about the matrix and the collagen. Could you say a little more?
Yeah, so obviously many projects let me backpedal. So as part of clinical practice, we don't always use tissue. So sampling would mean to take a tissue biopsy. And when you take a tissue biopsy, if you remember from the talk, there's both localized and systemic sclerosis. Ironically, tissue biopsies can't really tell the difference between a systemic sclerosis or versus a localized scleroderma. So we don't, unless we're thinking of a scleroderma mimicker, we don't always sample tissue as part of our clinical practice. Now, on the other hand, getting samples of tissue is very important for research. And when you're talking about how much collagen burden, that would be a pathologist doing that. So they could actually see under a microscope the amount of collagen that has been stacked, and stacked together in the form of that fibrosis. And then they do, on top of that, special stains to see which cells are active and which cells are not. So, for example, the myofibroblasts, which are, help making the secretion of the collagen. But this is more of a research situation than necessarily something that is used on a day-to-day basis in clinical practice.
Okay, great, thanks. Another question was, I had a positive ANA but no symptoms. What kind of follow-up should I have?
Yeah, that's an excellent question. Some of that is based on your personal preference. So as I said in the talk, the ANA itself is so nonspecific that it doesn't really tell us if a person is going to definitely have disease or not. It's actually more helpful in the reverse. It's if you're negative for your ANA, we can tell you with high certainty that you're unlikely to have scleroderma, though it's not 100%. Now, the follow-up to some extent will depend on if you have any symptoms that are tying you to scleroderma. So there are some patients that have a positive ANA and Raynaud's phenomenon. And that just those two things alone could be a clue that that patient may eventually manifest scleroderma. Remember, from what we know, it does seem like the blood tests are positive sometimes for several years before these connective tissue diseases like scleroderma manifest. If you have an ANA and nothing, your primary care doctor or some other doctor ordered the ANA, it was positive, and there's nothing else, then I would say I would leave that to your discretion about how much you want to follow up on that. But it is reasonable to follow up with a rheumatologist once a year for a few years just to see if anything develops. That's what I do with my patients sometimes.
Okay, well, that dovetails into another question, which had to do about at what point should a person leave their primary, not leave, but go to a rheumatologist and not just stay only with their primary care physician?
It is a very good question. I think anyone who has a positive ANA and there is some set of symptoms, either scleroderma related or other rheumatic diseases such as lupus, which remember, we have to remember that ANA is positive in multiple rheumatic diseases and autoimmune diseases. Scleroderma is not the only one. This is a Q&A specifically for scleroderma, but lupus, Sjogren's disease, dermatomyositis, all have positive ANAs, and it's just a few examples. So I think if someone has ordered an ANA for a discrete reason, your primary care doctor that is, and it's positive, then I think at that point you deserve an evaluation at least one time by a rheumatologist to see if there is some other disease that's sitting behind that ANA.
Great, thank you. Another question had to do with medications. So you kind of alluded to different medications, and what do you do when something isn't approved for use in this country? How do you approach that?
Well, there's probably there's two things. There's two parts to this question. There are medications that aren't approved for scleroderma, but are approved for other things. So that's one category of medications. And there are medications that are not approved at all to use in the United States for any purpose. The first category is one that truthfully we live as in scleroderma providers all the time, because there's only very few medications that actually have the FDA approval for management of scleroderma. Remember, the FDA approves medications as part of a very long and thorough process to make sure there's adequate benefit. And scleroderma being a very rare disease doesn't always get that level of scrutiny. So medications have been found to be useful that ultimately don't have FDA approval for the treatment of scleroderma. One example would be mycophenolate mofetil. So you will see scleroderma doctors sometimes using medications that are approved for other diseases, though they don't technically have an FDA indication. Now, on the second category, in medications that don't have approval for any sort of use in the United States, That's very difficult. Those are not able to be obtained in the United States. Now, some patients may oversee doctors overseas. There are some medications, like there's a medication called domperidone, which some scleroderma patients have used for treatment of GI symptoms. This medication has very restricted use in the United States, but you can get them in Canada. But that's a very challenging situation when you're using medications that have a very restricted use in the United States.
What about insurance coverage in the first group?
So the insurance coverage in the first group has become much easier. So I think it used to be, when I started practicing scleroderma, for treatment of scleroderma, the insurance companies were very restrictive in the sense that if they didn't have the FDA indication, they would not approve a medication. Now, I think if you see enough data, because there is scientific investigations, clinical trials going on these medications all the time, if you can show a clinical trial that shows some benefit, even if that benefit did not lead to FDA indication, the insurance companies will often approve the drug.
Yeah, in our family, cyclophosphamide was the first drug that my son was going to be put on, and we had to appeal it through all 3 tiers to get it. And this was 10 years ago, I guess. And then later, when he needed a stem cell transplant, still not approved, but the insurance he had at least reviewed the literature, and it was approved the first go round.
Yeah.
So the change over time.
Yeah.
Is there anything else you'd like to add about your talk? I think we have a couple of minutes left.
I think there are new things happening all the time in scleroderma. The clinical trials that you'll learn about later today are another way to get medications. There are some places in the United States where insurance coverage is not as robust for patients with diseases such as scleroderma, and you can use clinical trials as a way to get access to therapy if you're having difficulty with insurance approval, because then the medication is covered free as part of for the Conquest trial. So that's just another vehicle. I think also, as we are getting more and more advancements and more drugs, and our doctors are getting much better at treating scleroderma, I think we are moving forward in the right direction in minimizing the disease burden in patients, and that's a wonderful thing.
How do you counsel patients? Let's say something isn't approved. Do you handle the appeals, or do you ask the patients to handle the appeals? I mean, how does that go? What should patients know? People with scleroderma, what should they know about the process?
This is where having access to a scleroderma center is very helpful. So we have a lot of experience in getting approval for these medications. So because we have a lot of experience with scleroderma, so we do all the approvals ourselves. I can't speak for all the clinics in the United States. Everyone has their own format, but generally, most university scleroderma programs in the United States will help a patient get approval of medication.
Great.